until basically Dr. Adza came in 1995 or so that we started doing fetal surgery. So we were doing some deliveries, but they were usually in the operating room. So it was a lot to deal with, and a wonderful opportunity for me to work with actually some of the construction, where some of the equipment was going to be, because they were now developing an area here at this hospital for women to be able to either vaginally deliver in a room or to be C-section, depending upon what the diagnosis was for the infant. So the infant stabilization rooms were where we were going to be practicing the resuscitation of the infant, and then the respiratory therapist would then be transporting the infant to either the cardiac unit or to the NICU. It really tells an incredible story because the SDU is really special. You know, years ago, the mother might have known that they were going to be delivering a critically ill infant and delivered and not being able to be with their baby. Usually the baby then, if it was critically ill, was separated and the baby was transported to another hospital where a NICU was. So it gives us the opportunity to have a family-centered care where the mother can deliver right there, and the father and the mother won't be separated when the baby then goes to within the same hospital system. So this was back in 2005. I mean, some of the development discussions were talked about in 2002, but we started having meetings a few years before, and our team, respiratory care team, worked with who were we going to choose out of the 110 respiratory therapists that we have in our department. And so we looked at who we would want. So we wanted senior people, basically people who had delivery room experience, and there were a lot of people that worked here for a long, long time that didn't have delivery room experience. And so we kind of, at CHOP, usually we take a pretty strict you know, qualification thing anyway. So we wanted people to be the registered respiratory therapists in the Pennsylvania you know, state. We wanted people to have NPS. We wanted them to have at least 5 years of neonatal intensive care experience. And one of the things that we didn't have here at the hospital was the NRP program. So Patty Akoff and I, the educator, began an NRP program. And we were lucky because we were able to start the NRP program and then actually go through a couple of the years of going through recertification so that the people, we chose 19 respiratory therapists initially. Ann's going to talk about the training, but we chose first 10 and then we added on 9 more. So we only have 19 RT, respiratory therapists that are in SDU. So, I mean, what do we do in SDU? We basically assist the airway like you would do an algorithm for NRP. And it's more than that. Some of these babies, all these babies are born with congenital anomalies, so it's not just a meconium aspiration or a preterm infant. Some of the kids, when they come out, it's interesting with getting an airway and positioning the baby to get an airway and maintaining temperature and how you're going to ventilate some of these kids with some of the congenital diaphragmatic hernias that they have. And then it's transporting the baby to from the resuscitation area to one of the units. And so when we first started developing, it was learning all new equipment. We bought Panda beds that were a transport infant bed, and they actually have a neopuff built in. And I don't know how many people deliver here, but for me, I knew what a neopuff was because for 25 years I worked at another hospital with deliveries. When I came here, we were only doing deliveries, say, in the OR. So we learned, taught everybody how to use the neopuff, and then we also had to learn how to transport and work with the Panda bed, which was a built-in neopuff suction. It had tanks on the back of it, and even the equipment that we had as far as our resuscitation mask for the infant didn't necessarily go with the circuit. So wonderfully enough, in the training, we learned a lot of equipment, and we practiced through simulation how to do some of the transports and work with the equipment. And we ended up buying a ventilator, so sometimes in some circumstances we'll either have a ventilator or we'll have an oscillator in the delivery in the infant stabilization suite. For example, one of the babies that, when we had simulation, it was really neat because we tried to simulate the baby doll to make it look like similar to what we felt the diagnosis would be. And we practiced, initially we practiced the training in the brandly new built simulation center, infant stabilization room.
So as Leane said, we tried to do everything for the training using simulation, since we really didn't have any other options for anyone to go to other hospitals to get experience, or especially hands-on experience. So we did develop this simulation training course. And I just want to show you through this graph that shows the experience that the nurses and RTs had when they first started in the SDU, before they started. So you can see that the years of experience, both of respiratory therapy and nursing experience in their fields, was about the same, about 13 to 14 years on average. The years of delivery room experience, actually a fair number more respiratory therapists had some delivery room experience, and that was 6 out of 10. So 4 had no delivery room experience. But of the 6, many of them had up to 11 years of delivery room experience, and that was compared to our nursing delivery room experience. So most of the nurses had only maybe been in delivery for 3.5 years. But when you look at how long they were last in a delivery room, it was a long time. So most of them, the average time they were last ever in a delivery room was 10 to 11 years. And you can imagine that a lot has changed in the way we care for babies in the delivery room. NRP has had 2 to 3 changes in the guidelines and some pretty substantial changes. So we've had a lot to do to really get our staff up and trained for these new deliveries. So why did we choose simulation? So we feel that simulation really reinforces cognitive skills. So I can sit here and lecture about gastroschisis and omphalocele, and you will be able to understand the defect and potentially what you need to do, what special things in the delivery room you need to watch out for. I can take a lot of practice for technical skills. You know, there's a little intubating head that I can teach people how to practice intubation. I'm sure you guys have probably all seen them. There's all other types of task trainers that you can use to teach skills. But really, it's the whole thing of simulation lets you pull all these things in together and really allows the integration of behavioral skills, which is really what we don't get anywhere else. So how to work together as a team to make it a successful resuscitation. How to deal with all the other things that are going on around, not just knowing how to do it and being able to do it, but how do you put everything together in the stress of a real situation. Our simulations did all reinforce neonatal resuscitation guideline principles, even with the addition of anomalies. We did come up with specific guidelines that were anomaly specific, so what to do if it was a congenital diaphragmatic hernia, what to do if it was a gastroschisis. But we still follow the neonatal resuscitation guidelines. We included distractors in our simulations to make them as real life as possible. So have someone come in and play a parent, because family-centered care was clearly a big part of the SDU. And parents were going to be watching our resuscitations. They were going to be coming into the room and asking nurses and doctors questions. How do we deal with that? Obstetrical nurses and OB nurses come in and want to know, what are the AFGARs? How do you interact with that nurse? And tell them I don't have an AFGAR now because this kid's too sick for me to think about that. Or how do you work with an obstetrical nurse to get the information that you need? So why is my baby not as good as it should be? Why is the baby sick? Is there something in the maternal history that I missed that I need now to ask that OB person? We did things, some accidental, some non-accidental, with equipment failures. So a bag mask wouldn't work. Is there a hole in the bag? Is it not connected? What's going on? And that is something, again, that happens in real life. And if you include them in the simulations, it really helps to make it, one, seem more real, and it really helps people then get to prepare. And I think the other thing we learned with our simulations, especially preparing for the new unit, and Leane worked on this, especially with the Panda Bear, we learned a lot of things around the equipment in terms of the oxygen tanks on it. How long do they last going from the SDU to the NICU? Well, we learned that you can't run, there's only a certain amount of time you have with oxygen and suction going, and it depends on what your mixture is of room air and oxygen. And if we hadn't done